Hello and welcome. My name is Becky Leese. I'm the staff liaison between the Council of State Government's Midwestern office and the MLC Rural and Agricultural Affairs Committee. I'm joined today by um, my colleagues Sarah and Christina, and Tim Anderson is the liaison for the Health and Human Services Committee. As a reminder, this meeting is being recorded, and the recording and slides will be available at the end of the event, and it will be available on our website. We'll take questions at the end using either the Q&A feature or the raise your hand feature. Joining us today and moderating will be North Dakota Senator Paul Thomas and Teresa Ibaugh. They chair the Agriculture and Rural Affairs Committee. So Senator Thomas, could you get us started off, please?
Certainly, and good afternoon, everyone, and thank you for joining us today. Very special thank you to you, Becky, and also to Tim for organizing today's webinar. Earlier this year, members of the committee identified the Rural Health Transformation Program as a topic they wanted to explore in greater depth. In response, the CSG Midwest office organized today's discussion, and the topic will continue to be a focus at the MLC annual meeting, taking place this August 30th through September 2nd in St. Paul, Minnesota. We certainly hope to see everyone there. On the topic of artificial intelligence and healthcare, Robert Wachter will be a featured speaker at the annual meeting. Following his presentation, attendees will have the opportunity to participate in a rural healthcare breakout session led by Sanford Healthcare, the nation's largest rural healthcare provider. At the national level, the Council of State Governments is also examining these issues closely. Sean Sloan, Public Policy Manager at CSG and organizer of the annual Medicaid Leaders Development Academy, is currently preparing a 2026 Medicaid report that includes a section on the Rural Health Transformation Program. Today, Sean will provide an overview of state legislation regarding the implementation and oversight of the program. He'll be followed by Zil Joyce Dixon Romero, Senior State Government Affairs Manager at the National Rural Health Association, and Dr. Keith Mueller, Director of the Rural Policy Research Institute at the University of Iowa. As states, we were all given the opportunity to apply for the federal funding through the Rural Health Transformation Program. The program was designed to strengthen rural communities by improving healthcare access, delivery systems, quality, and outcomes. In December 2025, states across 11 state Midwest region were awarded approximately $2.21 billion through the program. Sean, we look forward to hearing from you first, and I'll let you take it away.
Thank you so much, Senator, and welcome everyone. As the Senator indicated, H.R. 1 included the $50 billion five-year initiative called the Rural Health Transformation Program, with $10 billion available each year. 50% of the funding is being distributed equally, and every state was guaranteed at least $100 million each year. And then there was a competitive process for the remaining 50% with allocations based on factors like rural population. But the program was intended in part to offset the legislation's cuts to Medicaid, which many feared would financially devastate rural hospitals and safety net providers that were already operating on razor-thin margins. Every state applied for and received money from the competitive part of the program that will help them implement a variety of innovative initiatives to revitalize rural health care delivery. The Centers for Medicare and Medicaid Services on December 29th of last year announced the first year state awards from the RHTP. The awards ranged from $147 million for New Jersey to $281 million for Texas. Among Midwestern states, Kansas was the big winner with nearly $222 million. And this is a map from our friends at KFF that shows the states that received less than $100 per rural resident from the fund, and those that received more than $500 per rural resident. And you see that among the Midwestern states, there were three were in the former category, so Michigan, Ohio, and Wisconsin, and only one, North Dakota, was in the latter. Next slide, please. But in recent months, we've seen some all too predictable headlines like this one from KFF Health News. This one is about a rancher in Hay Springs, Nebraska, who relied on the local hospital for dialysis sessions 3 days a week until the hospital abruptly stopped offering that service. The turn in the story comes a ways in when it notes that the 5 year Rural Health Transformation Program is aimed at exploring new creative ways to improve rural health, not to help existing services stay afloat. States can use only up to 15% of their funding to pay providers for patient care. Next slide, please. This was another KFF Health News headline earlier this year, and many remain concerned that despite the best intentions of states to craft innovative initiatives as part of this program, the money won't be enough to keep rural health facilities open or to reopen them, to solve the long known structural problems associated with rural health, or to offset the massive cuts to Medicaid elsewhere in H.R. 1. This story from North Carolina is about this place called Martin County, where the local hospital abruptly closed down in 2023, and it just completely gutted the healthcare system in that community. But those RHTP funds aren't going to help them get that facility reopened. North Carolina plans to distribute much of its $213 million allotment from the RHTP among existing health and social service organizations that remain open. There are also limitations on how much can be spent on construction and building renovations. Uh, and here's the full list of spending caps, which also included things like how much could be spent on replacement of electronic medical record systems, things like that. There you get the list of the programmatic spending caps. Next slide, please. So here is where the rubber hits the road, and we see that if one of the goals of the RHTP was to offset the Medicaid cuts elsewhere in HR 1, these funds are practically a drop in the bucket when you look at how states will be impacted. Texas, as I said, is getting $281 million for 2026, but faces a $4 billion decline in federal Medicaid dollars in rural areas over the next decade. If all goes well for Pennsylvania, they expect $1 billion over 5 years, but project 10-year losses of $20 billion. Which isn't to say that the many creative initiatives states are exploring with RHTP dollars aren't worth doing. Certainly, more than one thing can be true here. Next slide, please. Something else to note about how those initiatives came together, due to the short time frame states had to develop their applications for funding last year, it was executive branch agencies that led the way. In some states, it was the State Department of Health, in some places, the State Medicaid Agency, and in other places, it was the governor's office. Next slide. And in the Midwest, here's the breakdown of the agencies that led the way in each Midwestern state. Next slide. So, what are states spending the RHTP money on? Well, each state came up with diverse, localized strategies as part of their application. And I think our panelists this afternoon will dive deeper into specific initiatives. But at a high level, many of the initiatives were focused in four areas: technology and digital infrastructure, including expanding telehealth and remote patient monitoring, workforce development, things like offering signing bonuses to providers, relocation assistance, transportation, and child care support. Innovative care delivery, things like mobile health units and regional health hubs. And there were initiatives to address long-standing gaps in behavioral health services and chronic disease care. All worthwhile areas of focus. Go on to the next slide, please. But months after those RHTP applications and their various initiatives were approved, we have seen states where legislators sort of felt left out of the process, and so oversight legislation has been introduced in a handful of states this session. Lawmakers were successful in building in some oversight in Indiana and Kansas. In Mississippi, the governor vetoed another oversight bill at the behest of Dr. Oz. Lawmakers in Wyoming successfully killed one of the approved initiatives by declining to fund it. And elsewhere, legislators, stakeholders, or others inserted themselves into the process to express their reservations about how the money would be spent. Lawmakers in Ohio, for example, sought to ensure that the state was using the maximum percentage of funding allowed to support independent rural hospitals. The challenge with an added layer of oversight is that states have a limited amount of time to get RHTP initiatives up and running and demonstrate their value because there are clawback provisions in H.R. 1 if they're unable to use those funds in a timely fashion or to show progress. Go on to the next slide, please. But anyway, thank our other guests, I'm sure, can dive deeper into the various aspects of the RHTP. This is my contact information. Just to note that the RHTP will be one of the things on the agenda at our annual Medicaid Policy Academies in Washington, D.C. this year during the week of August 10th. We'll also talk about how the implementation of work reporting requirements is going and how states are approaching budget challenges on the horizon as the federal Medicaid cuts kick in. So if you are a legislator or executive branch official and would like to attend one of our policy academies, shoot me an email and I can provide more information. Thanks so much, everybody, and I will turn it over to Zill now.
You, Sean. Actually, you're turning it over to Teresa, but
Oh,
I will
sorry.
turn it over to Zill here in a second.
Okay.
I want to say thank you. It's nice to get an idea of where the states are actually at in this process, and you've touched a lot on you touched on a lot of the states and what they're doing, and finding new and creative ways to address rural health is both challenging and encouraging. You're correct, and I know here in Nebraska we've really focused on workforce development to try and increase the population and the opportunities for folks out in rural Nebraska. So thank you for that overview. You're correct. As lawmakers, one of the questions that we are asking ourselves is what are the other states doing? And to help answer some of those questions, now we're pleased to welcome Zill Joyce Dixon Romero, who is our senior state government affairs manager at the National Rural Health Association. And Zill, I'm sure as you'll note, you've been tracking these state plans and some of those CMS requirements and implementation efforts nationwide. We're certainly going to appreciate your perspective on where states stand today and what policymakers should be paying attention to as these programs kind of move forward. So I'll turn it over to you now. We're all very interested to hear your comments as well. So you're on.
Thank you so much, Senator. I'm going to go ahead and start sharing my screen here. One of the other lovely panelists want to give me a thumbs up that I've got it up right. There we go. I got one. Well, happy Monday, everybody, and thank you for that more than generous introduction. So I'm going to dive right in, and so we're going to talk a little bit about today some of the ramifications of RHTP and how it is getting deeper into the state level. I think Sean did a really great job of explaining the background of the program, but there are two additional points that I want to lay in on, which is, as Sean mentioned, the buckets of funding and the assessment of how much each individual state got was based on 50% baseline across the board in bucket A, and in bucket B, there was based on technical and rural factor data, which CMS then used to assess which states got more or less money. I want to start this here because this is a relevant topic that will come a little bit later, that this was the initial assessment, and CMS will continue to use these guidelines in years 2, 3, 4, and 5 to make assessments on how much your state is, quote, in need of rural health assistance. And so I'm not going to go through any of the more detailed numbers here, but I just wanted to give this list as an availability where there's rural factor data, which talks about absolute rural population, frontier population, et cetera, and the technical factors that include state-specific issues, that things such around health and lifestyle, certification of need, EMS, et cetera. And so this is something that we can see here, which is the strategic goals. So when your governor and then put in charge an individual who is going to be, quote, the de facto individual in charge of the RHTP program in the state, and they put together a proposal, these were the 5 strategic goal buckets that CMS encouraged individual states to then go after, which was in that make rural America healthy again, foster sustainable access, innovative care. And then the 2 that nearly every single state across the board did put some sort of investment in, which was workforce development and supporting technological innovation. We saw that all 50 states did something around workforce to attract, retain high-skilled healthcare professionals, and nearly every state put some sort of investment behind technological innovation that fosters those technologies that do effective care delivery, data security, cybersecurity investment, some sort of pipeline projects that will be able to get better wireless internet access to rural communities and improve data sharing, along with health information and technology, or HIT, technology investments. What that ends up looking like and sounding like when it comes to these specific states in the Midwest region. I wanted to make sure that there was at least one slide so you can see, not so that you can compare to one another, but that you can see how much more or less the states surrounding you got as a part of the fiscal award. As we narrow in, the higher end margin of what was awarded in the Midwest was in that 222 million, and the lower end was at 173. Basically, this is a pretty general, even and average split that we saw amongst most regions across the country. However, we are seeing different states doing different signature investments based on how much money they are awarded for the first year, as well as over the 5-year window. So you'll see in the second column, there's your fiscal 26 award. And then in the remaining column, it is usually either the signature or largest investment based on the 5-year aggregate scoring that you presented to CMS. This includes things such as community care preventative treatments in Minnesota, food as medicine in Nebraska, high quality access care is closer to home in North Dakota, and so much more. And so, where did states' designs and what did they have in common? And so, what most states had in common was in the workforce stabilization pipeline. We saw most states invest in rural residencies, grow your own strategies, typically tied to at least the 5-year service commitments based on exactly how much time and money was going to be given to rural over this period with the RHTP program. And then we saw a number of states put some money behind hub and spoke regional models, telehealth, and the big one, which we'll talk about in a few moments, AI and cybersecurity. There was also a number of states in the Midwest that put a heavy focus on aligning with the Make Rural America Healthy Again priorities around supplemental nutrition, food as medicine, and management programs. But when looking at the first structural basis, there were a number of states in the region that decided to use re-grant or hub and spoke model programs. A hub and spoke model program, for those who may not be familiar with it, is a model that concentrates capacity in an anchor institution that extends services outward rather than trying to build full infrastructure elsewhere all at once. And so we saw that Ohio, Iowa, Nebraska, Michigan all look to put additional dollars in regional networks for navigation, emergency responses, clinically integrated care network development, and other anchor telehealth equipment for recruitment and retention. Whereas we see in the regional re-grant program, which is programs that are distributing these RHTP dollars through intermediary organizations rather than directly to providers, saw some states look to build in regional coalitions, such as in Indiana, where they had 8 specific regional coalitions to help distribute the funds over time. We're also seeing in the workforce bunch. I decided to just use the very limited time that I had to focus on the 2 biggest tranches of funding that tended to become up when it came to your region. When we talk about workforce development, we saw that there's a massive push for pipeline training. The through line across multiple states is they're not just about funding slots, they're aiming to build a pathway to get students interested in committing to rural practices before they ever graduate. So we're seeing states like Indiana do a mandatory rotation in rural. We're seeing states like Kansas aim to build more niche-specific residency programs in rural rotations, including the first state's dental scholarship program. And we see in Minnesota, there's an earn and train apprenticeship model that they are copying from another organization to aim to get a little bit more OB services into rural clinician spaces. But the big thing that these dollars were aimed to utilize was to get that recruit and retain statements. So there was a dominant model here about service commitment incentives. States are essentially trying to entice or guarantee rural coverage for years to come, which the long-term goal, of course, of the program was to build that out, right? Was to say that this is not just it's not just about the 5 years of funding, it's about the next 50 years of development. And so states being able to ensure coverage in these rural areas through durable strategies of either recruitment, retention, or one-time signing bonuses to target providers and then put them into these areas in hope that they stay there. We are seeing a number of states put expanded training programs to improve and retain, especially in tribal areas. We're also seeing a readiness with a high school career pathway and clinical partnership program. These are just some examples of what's happening in the workforce development space, but it is not all that is out there. It is just some of the programs that we definitely have seen have been authorized, and states are looking to fund in a more expedited way. Turning our attention to technology and data, we have seen states put a lot of dollars behind the technological space. As I mentioned, it's one of the two buckets that nearly every single state puts some sort of reporting on. And so collectively, the 6 states listed here are committed to well over $1 billion of technological and data infrastructure in the Midwest regions. And so we are seeing states try to build data capacity on a foundation around the RHTP work. You're also going to note, because I know that it's mentioned and it's something that's going to be talked about in conferences and probably what we all should be thinking about as an element of technological innovation in rural, is that almost of these 6 listed, 4 of them did something to do with AI, whether it was AI application for clinical efficiency, AI early detection for chronic disease, AI models for remote patient monitoring, or all in all, AI investment software that then the state can utilize. This is something that CMS has been driving as a part of the programs and the technological and data investment. And I will just say that on this, we know that we're going to continue to have conversations around AI, but the most important conversation to have is if there is going to be AI influence in the Rural Health Transformation Program, it is very important to partner with the rural communities to help understand if that is something they want and they think is beneficial in their areas. And so moving up away from some of the minutia of what's actually in state programs to the reporting process. I know there's a lot of concern out there about what the reporting process looks like, sounds like, and feel like, and we understand that. Because to remain eligible to continue to receive funding in subsequent budget periods, awardees must adhere to program requirements, including the submission of annual and starting soon quarterly reports. CMS has put together a loose understanding of what that's going to mean, but it needs to deliver a summary of programmatic and funding activities at certain milestones, and then quarter reporting to serve as a tactical tool to ensure that there is no operational adjustments. The reason that this is happening is because CMS, unlike most either block grants or federal grants that come down the pipeline, has made it known that they will or consider clawing back certain dollars, which does mean that the state would have to pay the federal government back those dollars in some sort of process. And so to order to remain eligible for continued funding, states need to depend on those program authority, satisfactory performance, compliance terms and conditions, as well as with the knowledge that your award in year 1 may decrease or increase or be terminated in part if the requirements of your awards are not followed. CMS has put together a loose timeline of what this will look like. We know that just in the springtime in March and April, they did host a Rural Health Transformation Summit in the DC area, included initial programmatic visits in April, and now has told us that an annual reporting process and information about the reporting process will formally come out in August, because that is when the reporting process is expected to begin. In September through October, CMS will complete their rescoring assessments, and so that they can then have a better understanding of what that technical scores we talked about at the top of the slide deck will then be applied to the second year of funding. And then October 31st, they will announce information about year 2, and spending for the next budgetary year will begin. And in November, the new quarterly reporting rather than annual reporting system will take over. And so through years 2 through 5, Q1 through 4s in each of those years, there will become an ongoing reporting process. And September and October of subsequent years, there will become rescoring by CMS. And so that means that there will be initial eligibility participation that states must comply with. As we continue to see in the subsequent years, only states can be the ones that are the intermediaries between CMS and the RHTP funds. So as states start to award subawards and contracts, we are highly encouraging the folks running the RHTP programs to look to partners who understand federal reporting standards and look at groups that are fostering partnerships among rural providers, regional systems, stakeholders, and quality assurance, but also have a financially stable and access point in rural. We are also hoping that you will look at them with potential and groups that have a broader understanding of the rural knowledge and that you can help guide them up rather than eliminate them completely if they don't have the proper reporting tools. This is just a slide that I include on funding limitations. It is something to just keep in mind as people talk about those reporting processes, that if your state starts to approach either the capital expenditure cap or the provider payment cap, it's really important to keep that contact open with CMS to ensure you don't go over those restrictions. And with the last 10 seconds or so that I have here, the National Rural Health Association has put together our RHTP Center, which talks about announcements and shows between participation and review and agreed upon awards that are already out. And you can scan the QR code to look more about what your state is currently anticipating releasing, actively already has dollars out for, and or is currently in review. Thanks, everybody. I look forward to the conversation, and I'll turn it back over to the senator for the transition point. Thanks, everybody.
Thank you so much, Zell. That was very helpful, and it's helpful to hear both the similarities and the differences emerging across the states in their implementation plans. Certainly, that was something I was looking forward to, and each state is so unique and diverse in their needs that it's really good to hear what other states are doing. Another important theme is how states are using these funds to rethink healthcare payment models and create more sustainable systems of care in our rural communities. And to help us explore that topic, we're pleased to now welcome Dr. Keith Mueller. Dr. Mueller is a professor of health management and policy at the College of Public Health University in Iowa. And he also serves as director of the Rural Policy Research Institute and is widely recognized as a leading expert on rural health policy. In other words, few people are better positioned to help us today to understand the challenges and the opportunities facing our rural healthcare systems. I'm particularly interested in hearing Dr. Mueller's perspective on value-based payment models and how they might help rural hospitals and clinics move beyond reimbursement systems that are largely driven by volume. And many of us understand that. So Dr. Mueller, welcome, and thank you for joining us. We look forward to your comments now.
Well, thank you for inviting me, and I will focus on value-based payment in this presentation. The slides are coming up now, I think. Yeah, that's the late one. As we're catching up with the view, I'll just go ahead with the second slide. What is the value of value-based payment? We think of this is what really helps transformation. Just a pitch in that regard is to fully transform the healthcare system in a way that benefits everyone and sustain that transformation. We're going to have to realign payment incentives to go along with the transformed system. So there is that intrinsic appeal of a new payment design, as the senator just pointed out, to end the incentives of fee-for-service and volume-driven care to move us toward value. There's also an appeal to incorporate patient outcomes into patient design. So you don't get paid just based on an encounter, you get paid based on the outcome of patient care. And to benefit, if you can save money through value-based payment, and most of the initiatives will do that, potentially shift healthcare spending away from encounters for the sick and the injured to spending that keeps people healthy and other priorities. Next slide. So the commitment to transition to value-based payment is more than a one-time project kind of effort. It is something that requires considerable time. The timeline in the applications is using the full 5 years to reach implementation, which means you won't see all of the outcomes, both in quality and cost shifting, cost savings during the 5 years. You have planted everything so that you continue to see in progress in both quality and cost over time beyond those 5 years. To really do the transformation requires an all-in, as in all payers. Next slide. So as an activity within rural health transformation programs, it varies widely across the state programs. It could be an incremental approach, one service line identified, let's get our feet wet, let's get launched into value-based payment through a single service line. Another somewhat incremental approach is to use Medicaid only, at least initially, to launch efforts. A third incremental approach is a pay-for-performance approach, but without structural change. In other words, linking a payment to an outcome measure, but not linking it in any direct way to actually changing the structure of the delivery system. As a majority of activity in the transformation program could all be integrated into supporting the effort toward value-based payment and vice versa. In the states that I would characterize as having the most advanced programs, that's what they've done. They've integrated payment with another structural reform like hub and spoke, which Zil mentioned, with another reform area, change in population health, when I mentioned the benefit of moving the money around, and all of that being integrated into where they want to land at the end of 5 years and beyond. Next slide. So state health plans, at least initially, our view of this is that 23 chose an activity based specifically on value-based payment. Others incorporated redesigning the healthcare delivery system, targeting outcomes for patients and persons. Others brought in technology that supports the delivery of local services to improve patient outcomes. That can be tied back in to payment. And then what Zil covered, everybody addressed in one way or another healthcare workforce, including community health workers and others that address all of the circumstances affecting health outcomes, which is part of that value-based equation, including interaction with the clinical system and prior to somebody coming in for clinical care. Meeting the objectives and goals of MAHA can fall under that general characterization. And then following up after initial care with chronic conditions. Some high-level value-based payment initiatives across the board. I'm looking at all 23 of those states that we've created the database for. Nevada is looking to reward providers for improved outcomes and administrative efficiency through network programs. Colorado is exploring feasibility of shared savings and bundled payments, finalizing contracts by the end of year 5. Note again that long timeline to achieve actually getting to implementation. New Hampshire has an advantage of some previous work, so they're starting their first cohort in a new value-based pilot in 2027, with the second cohort coming on in 2028. Montana is exploring, this is an example of that incremental approach on service lines. They're exploring value-based payment for dual eligible special needs plans and using the PACE model, as well as value-based care for nursing facilities. Next one. Doing a dive into some specific states in our region. In Kansas, the program calls for adopting and operating a state-supported accountable care organization, or ACO. That's that shared savings model. Contracting with a national ACO management company for all their skills in developing all the back office software and information tracking it takes to be successful. That's going to be open to all the rural providers who are not already in some form of Medicare shared savings or the new ACO REACH program. It'll have incentives for participating rural providers, and it will develop new Medicaid managed care organization contract requirements. Next slide. Kansas has some specific goals. By 2031, all rural providers will achieve improvements on pay-for-performance measures identified as foundational. And by 2031, all the providers will actively participate in clinically integrated networks. Next one. Venturing out of the Midwest for a moment, the example of Louisiana is an intriguing one. Louisiana is focusing on high risk in sharing value-based arrangements between providers and high-need populations. They're looking at evolving the statewide system by piloting initiatives and care models initially, and utilizing community partnerships to serve hard-to-reach populations. So overall, they've got this focus on hard-to-reach, high-need populations using partnerships, including things like mobile units in care deserts, like the one identified earlier in North Carolina. If there's one like that in Louisiana, they're going to use mobile units to be able to reach patients there. Next slide. They have a specific timeline laid out so that by December of 2027, they're launching initial pilots and full implementation by September 31. Note the evaluation and preparation to spread pilots as they learn from them following the 2027 launch of pilots. One last state example is South Dakota. South Dakota has chosen value-based payment transformation through Medicaid reform. Remember the earlier slide, that's another sort of window into value-based payment to align financial incentives with health outcomes, to provide predictable revenue rewarding that rewards quality and incentivize preventive care. Next slide. South Dakota has specific stages in mind. So you can see they're starting from ground zero to develop value-based payments. They're going to define their goals, identify needs. Second step, they'll get to selecting vendors and creating quality reporting. And they're focused a lot on federally qualified health centers and rural health clinics. They'll staff and set quality metrics. They'll finalize the outcomes in step 4, and then in 5, quality, they'll analyze what they're achieving in quality and utilization. Next slide. There are some themes when you take this in-depth look at a few states, and we're continuing in our research center to add to that. In the early stages, they're laying the groundwork that can be accelerated. That early stage can go faster if there's something already in place. Missouri is an example of a state that already had some hub and spoke networks in rural Missouri that they developed through a Medicaid demonstration. So they'll be able to more quickly expand and go take that model statewide because they've already learned from 2 years of implementation. Models or pilots are the first step. That's another theme that's common across the states. And the scale varies a lot, just in the examples I gave you, from targeting certain providers or service lines to being fully comprehensive. Beyond just looking at value-based payment, some of the other initiatives in the state programs are related to the same concept. Again, the hub and spoke model is a way of changing the site of care and changing how you integrate care, both of which are part of the value equation. Using facilitating other network development. I mentioned in one of the states moving toward clinically integrated networks, creating building blocks to advance care management and accepting risk, bringing some of those workforce elements like community health workers. Population health initiatives pave the way for reducing utilization, which is a major measure of success with value-based payment. Success being don't have unnecessary utilization. That's an improvement in quality. It's also going to lower overall expenditures. And implement the uses of technology that improve effectiveness and efficiency. Some of those uses of AI that were in Zill's presentation. Next slide. To reach a wrap up, transformational change happens in these state programs through multiple initiatives, through the interaction across initiatives, timelines that extend the entire 5-year time horizon, consistent efforts to build to something that's sustainable, because you're changing the payment system, so you'll have a revenue stream that supports the transformational changes you've undertaken. Sustainability requires building the change into the ongoing financing of healthcare services. Next slide. So further information, a lot of what I've been drawing on comes from our research center. Every bit as much comes from a special project we do with a partner, Stratus Health, called Rural Health Value. And then a lot of our policy work comes through the Rural Health Panel. And I think there's one more slide with my contact information. And that's a wrap. Thank you.
Thank you so much, Dr. Mueller, and thank you to all our presenters today. For everyone online that may have a question, if you want to use the chat feature to send in a question, we'll certainly convey that. Or if there is a hand raised, we can also go through that process. I'm going to start with one that I kind of had for Zill. When you were giving your presentation, the recruit and retain you mentioned was a really popular payment or method that many states were looking at. And one of the things I was thinking of as you were putting that information out there and wondering, were any of the states that you're aware of coming up with some innovative ideas on recruiting people outside of the healthcare industry to become involved in the healthcare industry, recognizing that our healthcare worker shortages are not just in rural areas. Certainly, that's what we're focusing on and what we see most evident. But just an overall effort to try and increase the supply of the workforce in healthcare.
Yeah, I think that's a great question to start us off. As I mentioned, within the workforce space, almost every single state is going after some sort of workforce, and recruitment and retention is a big issue. And frankly, when we look at the HPSA designations or the health professional shortage area designations, there is a lot that is consolidated in the Midwest region. And so I have seen some states that are looking to I would not say that they are outside the healthcare realm model, but they are looking at midwifery, they're looking at doula care, they're looking at dental therapists, they're looking at expanding the scope of practice. That doesn't diminish the returns on what's actually a good quality health coverage, but they're looking at other expanded ways of practitioners being able to practice at either the top of their license or are looking at ways that they can recruit individuals to say, hey, this is a state that doesn't have this X program, or there isn't this topic of area at the universities in our state. What do we need to do to build up that gap? And I would say to the sort of second point to it, which is that because some states are openly utilizing that one-time bonus initiative, there are certain individuals that are looking more closely at rural communities. But I personally have not seen a state go out of its way to look at non-healthcare related individuals to put into the workforce pipeline because CMS has basically said that they weren't looking for external factors outside of healthcare or unless they're in the technology space, right? Tech's a little bit different. It's kind of its own tranche of funding.
Sure. Okay, thank you. We've got a couple questions that did come in. They're not directed to any particular presenter. So one of them are there benefits provided by a value-based payment model that are specific to rural areas that specifically address rural health challenges? Or are these new state plans and investments simply the result of a new federal program that is targeting rural health transformation in particular? Anybody want to take some comments on that?
I'll get us started with an example. The CMMI, the Center for Medicare and Medicaid Innovation, ran a demonstration project in Pennsylvania for a few years, the Pennsylvania Rural Hospital model. And that model was using something called global payment. So the hospitals were being paid by all payers, Medicare, Medicaid, and commercial insurance, on a quarterly basis with a global amount of money based on previous years' expenditures adjusted for circumstances like population change. The reason I start with that is that that demonstration started pre-COVID, and one of the early benefits during COVID, specifically for rural hospitals, because it was a rural hospital only, was they had a fixed revenue stream. Even when utilization initially dropped a lot, then went back up if they were the place with the beds for the patients. So that's an example of using a value-based payment strategy, global payment, to stabilize the revenue stream, which is the key, one of the key elements of stabilizing rural health, particularly in the hospital finance arena, is stabilizing and getting a more predictable revenue stream. Whether you use global budgeting or capitation for primary care, those are methodologies that, while the methodology may have been created in an abstract, it has clear benefits for the rural providers.
Okay. Okay, moving on. We've got some more questions that have come in. This is coming from a rural district. We only have one OB unit who is struggling with keeping doctors because they do not have a surgical robot. Are there any funds in the Rural Health Transformation Program that could help them get a robot for surgery? And then to add on to that, also anything to help for physical therapists or nutritionists.
Well, I guess I can start here. I'd have to do a little bit of a deeper dive into the minute. I think you said it was Michigan, correct?
Yeah.
Specific RHTP to see if they did put anything behind the technological space for that. So I would say just a brief pause on that one. I'll look into it and type an answer in the chat. And then as for physical therapists and nutritionists, we have seen broadly across the board some states using the Make America Healthy Again tranche of money for nutritionists and for folks specifically in schools. That's one of the big things that we have seen is folks that are looking to do either nutritionists in that elementary level as basically an assistance to the SNAP and WIC programs. And so there's some that are available in that space, but it is state dependent. So I'll answer that Michigan one in just a second in the chat as well, unless anyone else has got comments on that.
All right. An earlier one we had, Zill and Dr. Mueller, you had both mentioned the hub and spoke model plays a role in restructuring the payment method. How can rural health transformation dollars be structured to set up those programs with a potential end goal of then changing that to a value-based payment model? And also, do you see that as becoming more and more popular as we go forward?
Yeah, I'll take a first crack at that, and Zill may want to add to what I say. Because I can speak from experience in Iowa, which is one of the states that has identified hub and spoke as a major effort and is being built off of what had been previously called the Centers for Excellence program. And I want to focus on that because the hub is a rural hub. Oftentimes when people hear hub and spoke, they think big urban system as the hub and small rural as the spokes. In the Rural Health Transformation Program, the effort is to get it all rural. So, for example, in the Centers for Excellence idea, Iowa has already set up hub and spoke models for maternal care, where a larger rural hospital can handle the volume, it can generate sufficient volume for delivery, but then the spoke hospitals who can't do that can still do prenatal, postnatal, they can do emergency delivery connected to the hub hospital with telehealth. All of that means you can then get into an environment where you're accepting some of those more general payments like global or budget or bundle payment for that service line because you have found the most efficient and effective way of delivering the service. Iowa's program intends to extend that model to 4 other disease tracks, if you will. I know pulmonary being one of them. They have a separate model set up for cancer. It's called Combat Cancer. Also, hub and spoke. A regional hub in rural could do a lot of the infusion, for example. That you still need some volume to accomplish that, but you don't need the high volume of tertiary centers. You could do that in a regional way. Missouri's TORCH program is another example of having done that in their Medicaid demonstration.
Took the words right out of my mouth. I was even going to mention the Missouri Torch program, so good job.
All right. And so Sean and Zill, I think you both mentioned and kind of hit on legislative oversight and how it can be strained with divided control. You know, legislatures or bodies wanting to be involved, executive branches, all of that. Do any agencies have an innovative way of keeping the legislative oversight groups informed about the status of the program?
Um, I can start us off here. I think there's a number of states that have put together some innovative task force models or some sort of legislative reporting process. I often will turn to Nebraska, seems to be a really good example of the task force model. And we're one of the first states to actually put some sort of oversight legislation on it. We have also seen in other states, some states in their attempts to put oversight and have actually scaled back. So we saw in Mississippi, they tried to implement a sort of oversight legislative committee, and then it ultimately failed, and they opted to not do it. So I think it has become a very much a state level preference. But the big sort of models that we are seeing is either a temporary subcommittee on RHTP for like a 5-year interim where state legislators will get reporting back processes. We have seen in states like Arizona where they would like to use some sort of regional basis where they're getting reports from the different regions of the state that then come to the legislature either once or up to a quarterly per year. And then we are starting to see the task forces, right, where there is either some number of state legislators or their staff that are then helping with some sort of oversight. Sean, do you have any other states that you can think of in mind that would come to mind there?
I think just, generally it's interesting that we've seen the states where there's the party split between the governor's house and the legislature. In some cases it's that sort of dynamic that has caused the request for oversight. But then you have a state like Mississippi that they tried to get some the same party controls both, and you've seen states, you've seen the legislature pass an oversight bill there that was ultimately vetoed by the governor, and Dr. Oz actually stepped in and requested that they not do that. Um, so um, so it doesn't necessarily matter if there's a party split there, or I think the degree to which states were able to last year have a process in place that the governor or the Medicaid agency kept legislators informed about what the plan was, or incorporated them into the process. I think those are probably the places where things have gone best.
All right, we are getting close to calling it a wrap here, so maybe we'll go with one more question. Sorry for all of the questions that came in that didn't get answered, but this one specifically to you, Dr. Mueller. What changes for an MCO with a capitated payment system if they move to a value-based payment incentive? How is a value-based payment different or better?
Okay. Well, let's just start with the assumption that the capitated payment, what we're talking about is the payment from the state to the MCO organization. A lot of state contracts then say the MCO organization needs to use a value-based payment methodology when it pays the providers. So if you could have a capitated flow of revenue from the state to the MCO, then when the MCO is setting up payment agreements with providers, they're instructed to use something like a shared savings model or use a capitated model with those providers when they're dealing with them directly. So that would be a shift in value-based payment and incentives from just giving the MCOs a capitated amount and let them set the payment however they want. The other part of that question about utilization is also an important one, is utilization a perverse incentive? We have a lot of history of that being the case, but that history wasn't linking payment to quality outcome measures. So that when you're doing something like Pennsylvania's model did of trying to reduce preventable utilizations, they were linking out specific outcome measures, so they're protecting the outcome while saying you don't need to get there with overutilizing the healthcare system.
All right. Well, thank you. Thank you all for your presentations, and I'll turn it back over to Becky to wrap us up.
Yeah, thanks for the presentations to Sean, Zill, and Dr. Mueller. I appreciate your time today and the effort that you put into it to get things ready for today and being willing to reach out to our audience of legislative members across the Midwest and maybe nationally too, joining us today. So I also want to thank our audience members for tuning in. We appreciate your willingness to join. We'll make sure that this webinar is up on our website and it will be sent to people who registered for the webinar. Thank you to Christina and Sarah. I know this didn't go quite as smoothly as we had hoped. There were some technical glitches. Hopefully we'll get them ironed out next time, but thank you to everyone and have a great rest of your day. There are a couple more webinars coming up that our office is putting on. And I don't think I have a slide handy to show those. Maybe I do right at the end here. Let's see. Yes, we have, oh boy, it's going fast. We have the July 16th webinar about Reentry 2030 and a July 24th webinar on responding to nitrate contamination in Midwest waters. So get a look at our website if you want to join in on those. Otherwise, thank you and have a good rest of your day. All right.